Hello, is my voice is audible?
Yes, sir, I can hear your audio, sir. Please open your cam view.
Uh, am I audio? Am I visible?
Yes, sir. Your audio and video is good to go now.
Okay, 2 minutes. I will share the screen. I will stopping video. I will share the screen.
Okay, sir.
Is audible?
Yes, sir. Your
Yes, sir, I
voice.
can hear you. Just I will share my screen. My screen is visible.
Yes, sir. I can see your screen.
Slides is visible.
Yes, sir. Please change the slide, sir. Yes, sir. I can see the change also.
Slides is visible.
Yes, sir.
Okay. Now you are telling regarding YouTube something. What we have to do for that?
Sir, just unmute yourself, sir. I'll be calling you.
Okay, okay, 2 minutes. So we are going to start the session. First of all, good evening to all my students, and just we are going for discussion for oncology based questions. We will discuss here whatever questions they have asked in exam. One thing most of you have. So we are going to start the session. First of all, good evening to all my students, and just we are going for a discussion for oncology based questions. We will discuss here whatever questions they have asked in exam. One thing. Hello. So we are
Yes,
going.
sir.
So we are going to start now, and I hope so that this will be a very good interactive session for all students. Before starting the session, just we will take a five minutes. We will take for just basic discussions. Just we will wait all students to join, and we will wait to just hear about if any difficulty is there regarding screen sharing or any interpretation for listening the voice. If everything is all right, then we will start. This is totally oncology based discussion. Mainly, we will try to discuss oncology questions and endocrine questions, and it will take hardly around I think 1.5 and 2 hours for discussing all the questions. So if anything is there, any issue is there, you can post on chat. So after that only we can start. So I will wait for 2 or 3 minutes, and after that 3 or 4 minutes, and after that we'll go to start discussion. So all of my students who have given the exam, just I will tell that do not discuss regarding what is given in one textbook and what is given in another textbook. Whatever question they have asked, they have asked from standard textbook. Here also I will give you reference from mainly from Sevistans only. I am able to find out some more than 95% questions from Sevistans only, and from Sevistan only, that exact line by line they have given the questions. So question and answer from the Sevistan. Hardly 1 or 2 questions is there where you have to go and make some extra effort to get the answer. So for that, I have taken data reference also. Just before starting, again I want to confirmation with our students. Then we will start. Okay, I think they are telling everything is fine. So we'll start discussion. So I think this is the first question, most controversial question also. Most of the students have given some different answers. Mostly, I think confusion between A and B. So this one, I think this questions only came. A 25-year-old premenopausal woman with BRAF 5 lesion underwent lumpectomy year back. Now presented with only single mobile axillary lymph node in the same side of the axilla. Here they have given hint that same side axilla lymph node is there, which is mobile, and they ask for correct staging. What will be the correct staging? I will ask from you only, from our students only. Can they give answers? Then I will go to explanation. Please give answer in chat box, and then we will go for explanation. Can anybody will give the answer? Yes. So here answer will be Tx N1 Mx. So why T1 Nx Mx? Why not T0 N1 M0? Let me explain. So just go through this TNM classification. This is AJCC 8 classification. New classification is there. AJCC 8 classification. Just to see this encircle, red encircle, where it is written Tx. Tx means primary tumor cannot be assessed. Cannot be assessed means primary tumor either already previously operated, or either the tumor history or tumor operation history is not available. While T0 here for no any evidence of the primary tumor. Just see, Tx means primary tumor that cannot be assessed, means you are not able to assess prior history for the tumor. Is it excised previously? No any previous operation record is there. And T0 means there is no any evidence of the primary tumor, like carcinoma of unknown primary. Suppose a patient will come with only mobile axillary lymph node, right side of the axilla. There is no any previous history of lump excision, only mobile axillary lymph node you are having. Then the staging will be T0 N1 M0 here. But if already previous history is there for the surgery, and you are not able to find out the primary tumor, then it will be Tx. So here it will be Tx N1 Mx. Just I will explain here also. It is clearly given in TNM classification. See here, CNX, regional lymph node cannot be assessed, means previously removed. See this line, previously removed means already previously it has removed. Like same for Tx. C1 is metastatic to mobile ipsilateral level lymph node, which they have asked in our question. Okay. So here answer will be T1 and Tx and 1 Mx. Okay. So I think this everybody will agree for this answer. If it is carcinoma of unknown primary, no any previous history, then it will be T0 N1 M0. But if it is already surgery is there and only mobile lymph node, it will be Tx N1 Mx. Coming to next question. Second question, they asked a 12-week pregnant lady presented with complaint of 2 centimeter biopsy proven malignant lump in the breast. Which of the following correct for her treatment? So one hint here they have given that patient is having 12-week pregnancy, means patient is already in first trimester. Second thing, here 2 centimeter lump is there in breast, means here patient is having small lump, so C is a candidate for breast conservative surgery. So they ask for correct treatment. So option was like termination of the pregnancy and proceed to MRM. Second, wait till completion of pregnancy and proceed with MRM. Third, lumpectomy followed by chemotherapy. Fourth, lumpectomy with axillary dissection followed by chemotherapy. I will ask my student to give answer, then I will explain this answer. You can post in chat what will be the answer? What will be the answer here? No, it is not lumpectomy followed by chemotherapy. It is not lumpectomy followed by chemotherapy. Just post in chat, then I will tell you. Yeah, right answer will be here, lumpectomy with axillary dissection followed by chemotherapy. Now you will ask why not lumpectomy followed by chemotherapy. Let me explain. So just see this line. It is given in Devita, 11th edition, recent edition. Breast conservation contraindicated in situation that would require delivery of radiation therapy during pregnancy, but breast conservation may be attempted if the patient is in late pregnancy and RT would be administered after delivery. So here, what our question is saying, that patient is having 12-week pregnancy. So according to this, breast conservative surgery should be a contraindication. But now pregnancy is not a contraindication for breast conservative surgery. You can attempt breast conservative surgery even in first trimester. Okay. Thing is that only and only contraindication will be the radiation therapy. So here you can see the option. In none of the option they have mentioned any radiation. They only mention the chemotherapy here. See, chemotherapy, lumpectomy followed by chemotherapy, lumpectomy followed by axillary dissection followed by chemotherapy. So one thing already rule out here, that they didn't want to give radiation. Second thing here, that lumpectomy we can do, but and also after that we can give chemotherapy. Chemotherapy we can give in second trimester also. So here thing is that breast conservative surgery will include wide local excision or either quadrantectomy with that assessment of the axillary lymph node. Either you have to assess the axillary lymph node either by sentinel lymph node biopsy or either through axillary dissection. So for breast conservative surgery, not only you have to remove the lump, as well as you have to assess the axillary lymph node. So the answer here will be lumpectomy with axillary dissection followed by chemotherapy. Once you will complete the breast conservative surgery, after that you can go for chemotherapy in such patients. So right answer here will be answer D, lumpectomy with axillary dissection followed by chemotherapy. So you can do breast conservative surgery in pregnancy also, but thing is that for that you are not you can do breast conservative surgery, but you are not able to provide the radiation in first trimester. Okay, so right answer will be the lumpectomy. Lumpectomy with axillary dissection with followed by chemotherapy. Third question, I think they have asked like some not exactly same image, but I think like same image they have given, and they have asked most common malignancy will be seen in FNAC or either biopsy of below mentioned images for a patient. Okay, I think they have given option the ductal carcinoma in situ, lobular carcinoma in situ, infiltrating ductal carcinoma, or atypical ductal hyperplasia. Can anybody give the answer in chat box? Then we will further proceed. Please give the answer in chat box. Please give the answer, then we will further proceed. What will be the answer here? Yes, I think students are no image was there, but according to students only I kept this image. Like I think they have given mammographic image. If image is not there, and if they have asked directly like in mammographic calcifications, what will be the most common malignancy? Same option can be there: DCIS, LCIS, IDC, and ADH. Atypical ductal hyperplasia. Can somebody tell the answer? Okay, I will explain the answer. Answer will be the DCIS, ductal carcinoma in situ. Let me explain. So this lines same exactly came from Devita. Finding on mammogram in patient with DCIS include clustered calcification without an associated density in 75% of the patients. Means 75% of the patient in mammogram will definitely have clustered calcification with DCIS. Okay, calcification can coexist with associated density. Density means either it can be a fatty breast, either it can be a parenchyma that can be associated with 50% and density alone in 10%. So you can see here at least 90% of the DCIS will have calcification on mammogram. So like if such mammogram will be there and if you are going for biopsy, definitely there will be some DCIS component will be there, or either it will be a DCIS. So here most suitable options, or what most suitable right option will be the DCIS. So here answer will be the DCIS. If suppose this calcification is there, microcalcification if you are seeing, and if mammographic wise they have given, most commonly the DCIS will come in histopathology. Also, you can see here the calcification seen on mammogram generally corresponded to the area within the central involved duct in which there is often necrosis and debris. So this ductal carcinoma in situ mainly arising from the ducts only, where it will form the microcalcification, which is like a clustered calcification. So like if suppose in this such image is there, and if you are going for biopsy, definitely the biopsy will come as ductal carcinoma in situ. Okay. So coming to third question. Here they have asked one question regarding calcitonin level in medullary carcinoma of thyroid patient. Which of the following preoperative serum calcitonin level will warrant central plus ipsilateral neck dissection? Just again see this. Central plus ipsilateral lateral neck dissections mean they have asked for central neck dissection, not for only unilateral central neck dissection. They asked for bilateral central neck dissection plus ipsilateral neck dissection. They have given less than 20 picogram per milliliter, 20 to 50 picogram per milliliter, 50 to 200 picogram per milliliter, and 200 to 500 picogram per milliliter. Can somebody give the answer? Even if it is 150 by 200, can somebody give the answer? Then we will go for further explanation. Yes, here right answer will be here 50 to 200 picogram per milliliter. Let me explain. This question they have asked directly from Devita. So as such line is given in Devita for research. So recent guidelines is recommended thyroidectomy only, specifically in medullary carcinoma of thyroid patient. Suppose a patient of medullary carcinoma of thyroid came to you, and if you are taking a basal calcitonin level, and if it is less than 20 picogram per milliliter, if bilateral node is not palpable, if there is no any palpable central neck node, these two conditions should be there. If bilateral, no any palpable lymph node. If there is no any palpable central neck node. These two palpable things you can either see clinically or either radiologically. Okay. If both two things is absent, and if basal calcitonin level is less than 20 picogram per milliliter, only thyroidectomy is sufficient for such patient. Only thyroidectomy is sufficient for such patient. So you have to take decision according to the basal calcitonin level. Okay, ipsilateral central and lateral neck dissection, if the calcitonin is 20 to 50 picogram per milliliter, means you have to do ipsilateral central neck dissection and ipsilateral lateral neck dissection if value is 20 to 50. But if value is 50 to 200 picogram per milliliter, you have to do contralateral central neck dissection also. So always neck if they have not specifically mentioned for central neck dissection, it will always and always be bilateral central neck dissection. Okay, so here they have asked for central neck dissection plus ipsilateral lateral neck dissection. So for that you have to go for value 50 to 200 picogram per milliliter. Okay, so if value is between 15 to 200 picogram per milliliter, then you have to do central bilateral central neck dissection as well as ipsilateral lateral neck dissection, what they have asked. But suppose if value is more than 200 picogram per milliliter, then you have to go for bilateral lateral neck dissection. Means you have to do central neck dissection, bilateral central neck dissection. With that, you have to go for bilateral lateral neck dissection. Okay, clear? So here they have asked, in medullary carcinoma of thyroid patient, which preoperative serum calcitonin level will warrant central means bilateral central compartment neck dissection. They have not specifically mentioned unilateral. Central means always and always bilateral central with ipsilateral lateral neck dissection. So only and only this value is there, which is matching with that same criteria. So answer will be, even if it is 150 and 150 to 200, that same you have to take, and it will be like till 200 you have to go for ipsilateral lateral neck dissection. Okay, so answer here will be 50 to 200 picogram per milliliter. Okay, coming to next question. This question I think everybody have given I think right answer for this question. Which of the following is not a risk factor for male carcinoma of breast? Okay, they have given answer: Klinefelter syndrome, BRCA2 mutation, gynecomastia, and family history. Can somebody give the answer in chat box? Then we will further proceed. Okay, so answer here will be the gynecomastia. Okay, so gynecomastia is not a risk factor for male carcinoma of breast. Let me explain. So just remember, male carcinoma of breast is very rare carcinoma. It is account for only 1% of the all breast carcinoma. All breast carcinoma means including male plus female. Around 1% is account for. Second thing, the patient with male carcinoma of breast is behave much more aggressively compared to female carcinoma of breast. What is the reason? Reason is that these patients are having BRCA2 mutation. Okay. Second thing, BRCA2 mutation is more specific for male carcinoma of breast. Okay. So the risk factor, what will be the risk factor? Increasing age, radiation exposure, disease, estrogen and progesterone unbalance like testicular disease, infertility, obesity, cirrhosis. If patient is having already cirrhosis is there, testicular atrophy will be there, Klinefelter syndrome, and familial history with that BRCA2 mutation. So these are the factors which are associated with male breast carcinoma. But Srivastava specifically they have mentioned that gynecomastia is not a risk factor for breast cancer, male breast cancer. Okay, so here right answer will be gynecomastia. Gynecomastia is not a risk factor for male breast carcinoma. Okay, clear? Coming to next option. Next question, they asked orphan NEI nuclei seen in. I think this question they asked, orphan NEI nuclei seen in. Option was medullary carcinoma of thyroid, papillary carcinoma of thyroid, follicular carcinoma of thyroid, and anaplastic carcinoma of thyroid. I hope so all of students have given right answer for these questions. You can post in group, or you can post on chat box, then we will further proceed. Yes. What will be the right answer for orphan NEI nuclei? Yes. Somebody is typing C. It is not C. It is not follicular carcinoma of thyroid. It is very common question. I think it is a very common question, very common histopathological finding for thyroid carcinoma. What will be the right answer here? Yes, I will explain. So right answer will be here, the papillary carcinoma of thyroid. It is a characteristic feature for papillary carcinoma of thyroid in histopathology. Okay, let me explain. So just remember this thing. This is not for this exam. Already, if you are giving in further exam, they can ask this question definitely. Fine needle aspiration performed with small gauge needle. Typically either 23 or 27 gauge. This 2 gauge is there. With that, they can do FNAC through the thyroid, and it may be performed either direct or either from suction technique. So two techniques is there. Either you will directly put the needle inside the thyroid and the material will come, or either you put the needle inside the thyroid suspicious area and you have to suck, then the material will come. So two techniques is there. One, it will come through capillary action, or one with it will come with suction action. Okay, so two techniques. So in semester it is already given that PTC histologically characterized by complex branching papilla with pseudo inclusion, nuclear grooving. Nuclear grooving is very characteristic feature. Psammoma bodies is calcified bodies, concentric calcified bodies, and orphan nei nuclei. These characteristic is for papillary carcinoma of thyroid in the histopathology. Okay, so here answer will be papillary carcinoma of thyroid. Let me explain. Just I have taken this picture. What is orphan nei? What is orphan nei picture? Actually, orphan nei is a cartoon character, previous cartoon character who is having only the eyes, no any pupil is there. It is like a hollow eye. So from that, it is look like the nucleus is look like same only like orphan nei. They have concentric and they push to the lateral aspect, and only cytoplasm you are able to see. So look like the same eye they characterize the orphan nei nuclei. You can see here, this is orphan nei nuclei like feature. Orphan eye. And this is nuclear groove. You are seeing this one line is that this is nuclear grooving. This line you are seeing, this is nuclear grooving. This line, nuclear grooving. So nuclear grooving and orphan nei characters. Orphan nei characters is specific for papillary carcinoma of thyroid. Remember, 23, 27 gauge, 2 action, capillary action, suction action. With both, you can take the FNAC characteristic feature, nuclear grooving, psammoma bodies, orphan nei nuclei. These are the this is the standard question. Always they will ask in exams. Okay, so here answer will be papillary carcinoma of thyroid. Okay, coming to next question. Next question, they ask which of the following is not a feature of malignancy. Just for before going discussions, I will tell you we have done Fantastic 5 series. In that Fantastic 5 series, I have taken general oncology class. In that general oncology class, I already discussed that they can ask that 10 specific characteristic of cancer, which is given by Weinberg. For this question is from same from the 10 characteristic features. They ask, they can pick up any 3 or 4 like that. Here what they have given: evade immune destruction, evade autophagy, evade apoptosis, invasion, and metastasis. Can anybody give the answer? Then we will further proceed for explanation of the answer. Just please give quick answer. Give quick answer. Yes, somebody is giving the answer. Evade autophagy. I want some more. I want some more response from the students. Then only it will be a good discussion. Can somebody type in this answer box? Yes. I think everybody is giving the right answer only. Here answer will be the evade autophagy. So answer will be the evade autophagy. Okay, let me explain. So just see this picture. I am telling if you are going for INISS, if you are going for JIPME ramps examination also, just remember this picture. They will ask definitely 1, 2, 3, 4 any type of characteristic from Weinberg hallmark, and they can form the question. So here already 3 options is given: activation, invasion, and metastasis already in our option. Resisting cell death means evading the apoptosis, already in our option. Avoiding immune destruction, evading immune destruction, already in our option. Only one option is left behind, that is evading autophagy. That's why here answer will be the evading autophagy. Always and always remember this 10 characteristic feature for formation of carcinoma. They can ask in upcoming exams also. If you are planning for INISS, just remember this picture also, because they can ask from here. Okay, Let me explain regarding the autophagy. Why they have put autophagy as an option. So it is given in data that nutrition starvation, radiation therapy, certain cytotoxic drug can reduce elevated level of autophagy that apparently protect cancer cell. Okay. Moreover, severely stressed cells have been shown to shrink via autophagy to a state of reversible dormancy. So they have told here cell will shrink and they will go for dormancy. But what next they have told, this particular survival response may enable the persistence and eventually regrowth of some late stage tumors. Here they are telling that autophagy is promoting for carcinoma formation. Here they are telling following treatment with potent anti-cancer drug. Okay. Last they have mentioned together observation like these indicate that autophagy can have dichotomatous effect. It is not like always it is suppressed. It is not like always it is support. It is dichotomatous effect on tumor cell and thus tumor progression. Okay. That's why, so autophagy is a dilemma. It either can promote, it either can suppress the tumor formation. So autophagy is a dilemma. That's why they put specifically this option, evade autophagy. So here option will be autophagy. 3 options already from the Weinberg hallmark. So all option will be the evade autophagy will be the right answer. Okay. Coming to next question. This question, a female presented with 1 centimeter nodule in the right lobe of the thyroid, on investigation found to have medullary carcinoma of thyroid with no any significant node in USG. Okay, which of the following is correct for her treatment? Now somebody can ask that, sir, in previous question you have told that if no any central neck nodes, if no any lateral neck nodes, then we have to go for serum calcitonin value, and according to that we have to decide the treatment. But in this question, neither they have mentioned the serum calcitonin level, neither they have mentioned any clinically palpable lymph node. Okay, they ask the standard treatment for medullary carcinoma of thyroid. Okay, if you are going through the ATA guidelines, definitely you have to take the serum calcitonin level, and according to that you have to take the decision. You have to go for central neck dissection, or either you have to go for lateral neck dissection. But why they are preventing for central neck dissection? Because if you are going for central neck dissection, chances of injuries, vital structure injuries will be high. Either you are going to injure the inferior thyroid artery, either you are going to injure the recurrent laryngeal nerve. Okay, so recently they published like that. But if you are going for standard treatment, if they ask like that, if they have not given the calcitonin value, and if they ask for standard treatment, we have to go for standard treatment also here. Okay, so what will be the standard treatment? Can somebody give the answer? Can somebody give the answer in chat box? Yes, please. Then we will further proceed. Can somebody give the answer? Somebody is giving total thyroidectomy plus central compartment neck dissection. Yes, right. Yes. Okay, let me explain the answer. So here answer will be the total thyroidectomy with central compartment lymph node dissection. Okay, let me explain. So this line is given in Sebiston. Okay, what they have written: clinically evident medullary carcinoma of thyroid is treated with at minimum, just see here, at minimum total thyroidectomy and bilateral central neck dissection, as central node metastases are present in more than 70% of the cases with palpable tumor regardless of the tumor size. Please understand, here they have followed the common guidelines. Okay, so if any patient from medullary thyroid carcinoma is coming to you, and if you are not having the facility for serum calcitonin, and suppose if you have go for surgery, if you want to do surgery, the standard surgery will be the total thyroidectomy with bilateral central compartment neck dissection. That will be the standard treatment. Okay, So here, if suppose like that, same here they have mentioned that female patient with 1 centimeter 1 centimeter nodule with FNAC diagnosed medullary carcinoma of thyroid, no any significant neck node. What will be the standard treatment? Standard treatment always and always total thyroidectomy with central compartment neck dissection. So your answer will be the B, total thyroidectomy with central compartment neck dissection. Also, Srivastava support this statement that if you are going for standard treatment, you have to go for total thyroidectomy with bilateral central compartment neck dissection. Okay. Okay. Coming to next question. They ask most common site for extragonadal germ cell tumor. Option was anterior mediastinum, posterior mediastinum, medial mediastinum, retroperitoneum. Can somebody give the answer in chat box? Then we will further proceed. Please give the answer in chat box. What will be the right answer here? Most common site for extragonadal germ cell tumor. Answer. Somebody is giving answer B. Posterior mediastinum. No, posterior mediastinum is not a standard answer. Not a standard site. Somebody is giving answer A. Please give the response. Then only we will further proceed. Answer yes, please. Yes. This right answer will be the A, anterior mediastinum. Okay, let me explain again. That same line I have taken from Srivastava. Specifically, they mentioned Srivastava with mediastinum in our chest chapter, chest where they have covered the pleura, mediastinum, lung. They have written there. Just you can go and see in the same page number 1633. They have written between the age of 10 to 40-year-old, lymphoma and teratoma. Teratoma is non-seminomatous germ cell tumor. This type of germ cell tumor. Lymphoma and teratoma in women. Okay. And lymphoma, seminoma, and non-seminomatous germ cell tumor. Seminoma, non-seminoma is also germ cell tumor. And teratoma in male are the most frequent occurring neoplasm of the anterior mediastinum. Please understand, here neither option was there for lymphoma, neither they asked for lymphoma. So lymphoma is ruled out already. Next, second most common is teratoma. Teratoma is non-seminomatous germ cell tumor or germ cell tumor, which is most common in anterior mediastinum. Okay, and in our question they ask most common site for extragonadal germ cell tumor. Extragonadal means outside the gonads, outside the testicular area, and that area will be the mediastinum. So answer here will be the anterior mediastinum. Most common site for extragonadal germ cell tumor is anterior mediastinum. However, just remember, most common tumor in anterior mediastinum is thymus. Most common tumor in anterior mediastinum is thymus. Second most common is lymphoma. Third most common is non-seminomatous or germ cell tumors. Okay, so here answer will be the anterior mediastinum. You can go and see in the Hebster that same line they have taken and formed the question. Coming to next question, here they ask which of the following is not a risk factor for breast carcinoma. This is also a common question. If you will remember estrogen related factors, familial factor, you can give answer easily. So they ask atypical ductal hyperplasia, atypical lobular hyperplasia, fibroadenoma, and florid hyperplasia. Can somebody give the answer? What will be the right answer here? Can somebody give the right answer? Then we will further proceed. Which is not a risk factor for carcinoma of breast? Yes. Right answer will be C. Fibroadenoma is not a risk factor for CA breast. Okay. Let me explain. This chart is given in our Hebster. Okay. This chart, this table is given in our Hebster. See here, last histological risk factor, where they have mentioned proliferative breast disease, atypical ductal hyperplasia, atypical lobular hyperplasia, and lobular carcinoma in situ. These all four things is risk factor for breast carcinoma. Already they have given atypical ductal hyperplasia. Already they have given atypical lobular hyperplasia. only for proliferative breast disease they have given the option like florid hyperplasia. So they want to confuse you between the fibroadenoma and florid hyperplasia. So see the next table which is given in Srivastava. Florid hyperplasia is also known as ductal hyperplasia and included in proliferative disease. Okay, it is a type of proliferative disease. Okay, and just see this table. Non-proliferative disease estimated risk of recurrence is 1, while proliferative disease without atypia it will reach up to 1.3 to 1.9. So it is a type of ductal hyperplasia, which is a proliferative disease without atypia, and the relative risk for carcinoma formation will be between 1.3 to 1.9. Okay, so it is also a risk factor for carcinoma formation. Okay, so here right answer will be the fibroadenoma, because atypical ductal hyperplasia already given, atypical lobular hyperplasia already given in table. Florid hyperplasia like proliferative breast disease, ductal hyperplasia, which is also a risk factor for carcinoma of breast. Right answer will be the fibroadenoma. Okay, so answer will be the C, fibroadenoma. Okay, remember this table, this different some next, and they can ask different types of option for risk factor for carcinoma of breast. Mainly they can ask for genetic predispositions. Coming to next question. So they ask most common clinical manifestation of Feochromocytoma. They ask question most common clinical manifestation of Feochromocytoma. Clinical manifestation, just see most common, not symptom. Not symptom. Symptoms means patient will tell. Okay, clinical manifestation, sign they ask: headache, hypertension, palpitation, sweating. Can somebody give the answer? Then I will further proceed. Can somebody give the answer? What will be the right answer? Just put on chat box. Put on chat box. Then we'll see. Yes. No. Headache is not a sign. It is clinical manifestation. Clinical manifestation means sign, not symptom. Symptom means my patient will come and tell to you, I am having the headache. Symptoms means patient will tell. Here they ask clinical manifestation. Sign they ask. Answer, yes. Right answer will be the here. Right answer, let me explain. Right answer will be the answer B, hypertension. Okay. Again from Srivastava, go to page number 981. Specifically, they have mentioned that a subset of the patient with classical triad, they can present with symptoms of headache, diaphoresis, and palpitation. These are the symptoms. Patient will come to you and tell, I am having the headache, I am having the perspiration, I am having the palpitation. These are the symptoms. But hypertension, it is present in 90% of the cases, and it may be episodic or sustained. So this is the sign. Most common sign is hypertension. Okay, so most common clinical manifestation will be the hypertension here. So right answer will be the hypertension. Most common clinical manifestation for Feochromocytoma is hypertension. One thing you have to remember, even 100% patient you will take for diagnosis, 100% patient you will take who are having hypertension, hardly 0.1% patient will have diagnosed as a Feochromocytoma, even though it is a most common clinical manifestation of Feochromocytoma. Okay. One more thing you have to remember, Feochromocytoma is associated with Mann syndrome. So you have to rule out other Mann deformities or other Mann abnormality which is associated with Feochromocytoma, like medullary carcinoma of thyroid. Okay, so you have to give serum calcium. Okay, you have to get serum calcitonin, and you have to rule out these entirely before treating the Feochromocytoma. Okay, so here right answer will be the hypertension. Coming to next question, they ask which of the following drug is not used in thyroid dystrophy. They ask which drug is not used for thyroid dystrophy. I think this is basic general surgery question. If you will rule out option by option, you will rule out the question, you will rule out the drugs, and you will take the right answer. Can somebody give the answer? What will be the right answer? Please put the answer in chat box. Please put the answer in chat box. Yeah, right answer will be the aspirin here. Okay, let me explain for this question. This is also given in Srivastava thyroid chapter only. Pre-operatively in hyperthyroid patients, Graves patients, pre-operatively patients should ideally be rendered euthyroid. You have to make euthyroid before surgery, otherwise patient will develop. If it is hyperthyroid, patient will develop thyroidism. Okay, euthyroid prior to thyroidectomy with anti-thyroid medication. They specifically mentioned typically today it is the methimazole or carbimazole, because PTU, propyl thiouracil, was found to be associated with liver failure. But in our option, they have given the option for propyl thiouracil, not methimazole. But it is also an option for anti-thyroid medication to reduce anti-thyroid. You can add beta blocker. Okay. Third is high concentration potassium iodide solution, including Lugol solution for supersaturated potassium iodide, can be given for 7 to 10 days prior to the surgery. So all three drugs they already mentioned in the book, and all three drugs they ask in the option: beta blocker, propranolol, propyl thiouracil, which is an anti-thyroid medication, Lugol's iodine, which is a concentrated iodine for decreasing the vascularity of the thyroid. Okay, so right answer here will be the aspirin. Okay, so right answer here will be the aspirin. Okay, coming to next question. Next question, they ask for the staging of thyroid cancer. A 44-year-old female presented with 3 centimeter thyroid nodule, which show involvement of the step muscles with significant lateral neck nodes on the same side on USG. What will be the clinical stage? Can somebody tell in answer box? This is quite tricky question. Guidelines, some little bit change is there. Some change they have made in the new AJCC guideline, and this question is based mainly on this changes of that guideline only. Can somebody give the answer? Can somebody give the answer in chat box? Then I will go further proceed. I will further proceed for explanation. T3B and stage 1. Okay. T3B, B, T4 and stage 1. No, it is not T4 and stage 1. C, T3 and stage 2. No, it is not T3 and stage 2. Stage 1, C. So different answers is coming. Option is stage A. Okay. Okay, let me explain what will be the right answer. I think some different answers are coming. So right answer will be the T3 stage and stage 1. Category wise it is T3, stage wise it is stage 1. Let me explain. So this is the recent classification, AJCC classification. See T3, what they have mentioned in T3, tumor more than 4 centimeter size but limited to thyroid. Okay, either it is more than 4 centimeter limited to thyroid, or gross extrathyroid extension, means it already invade the capsule and goes outside the thyroid and invade the step muscles. Only step muscles. See here, only step muscles involvement. So only step muscles involvement is T3. Okay, they ask involvement of the gross extrathyroid extension and step muscles involvement. Only step muscles involvement is T3. It can be categorized if they have specifically mentioned T3A, T3B, then you can go for specifically for T3B. If they have given only T3, then it will be a T3. Okay. So T3A, if it is limited to the thyroid more than 4 centimeter, but it definitely T3B means if it is extra thyroid extension, if it is involving the step muscles. See here, this is the new changes here. Previously it was 45 year. Now they have increased to 55 year. Why? Different study they have seen that the life prolongation, chances of survival increase in last 10 years in thyroid carcinoma from 45 years to 55 years. So previously it was 45 years. Now they have changed to 55 years. Okay. So if any patients who is less than 55 years, any T stage, either it is T4 T4A, T4B, T1, T2, T3, any T, any N. I told ipsilateral neck node. Ipsilateral neck node will come in N1B. Ipsilateral center net will come in N1A. But here they mention any N. Okay. So any T, any N, but no any metastasis will come in stage first. Will come in stage first. So here no any metastasis is there. So patient will come in stage first. If they mention the patient is having metastasis to the lung or patient is having metastasis to the bones, then it will come as stage second. Okay. So here answer will be, if specifically they have given option, whatever I have recalled, according to that I have framed the question. But specifically if they have given T3B stage 1, answer will be definitely T3B stage 1. Otherwise it will be answer, if they have given T3, then answer will be T3 stage 1. Okay. So answer will be here. Our answer will be here T3 and stage 1. Okay. Right answer will be the T3 stage 1. Yeah. Okay. Just for your knowledge only, and for the students who are really want to go for AIMS and JIPMER exam, for that for their knowledge, because they can ask this question also. Anaplastic carcinoma always and always stage 4. Either it can be a stage 4A, stage 4B, or stage 4C. Always remember, if metastasis is there in anaplastic carcinoma, it will be stage 4C. Otherwise, if it is no any lymph node is there, stage 4A. Rest all is stage 4B. No lymph node is stage 4A. Metastasis stage 4 is stage 4C. The rest all will be the stage 4. Okay. Coming to next question. Next question was, if a 30-year-old premenopausal lady presented with 1 centimeter lump in left breast, no any palpable axillary lymph node, underwent lumpectomy, what will be the next treatment? Just see all 4 options: adjuvant radiation, adjuvant chemotherapy, observation, completion mastectomy. Just give the answer. Give the answer in chat box. Then I will explain. Please respond for the answers, so I can understand that all of you are there and you are able to see. Just give the answer. What will be the answer? No, it is not C. It is not C. Observation is not a answer. Why we will observe? Observation is not a treatment for such type of patient. A. Somebody is giving the answer A. Somebody is giving the answer C. Okay, let me explain. Right answer will be here. Answer is A, adjuvant radiation. Okay, let me explain for this question. Ideally, for this patient, if 1 centimeter lump is there, if you are going for only lumpectomy, you have to address the axilla. You have to definitely address the axilla in this patient. But in this options, neither option is there for addressing the axilla. No any sentinel and lymph node biopsy, no any axillary dissection. So one step they already skipped. Now they came to next step. What will be the next step? So always remember, breast conservative therapy means axillary lumpectomy, quadrantectomy with axillary lymph node dissection or sentinel lymph node dissection with adjuvant radiation. This is the complete treatment for breast conservative surgery. Okay, this is the complete treatment for breast conservative surgery. Adjuvant radiation is must for breast conservative surgery. If patient is not a candidate for radiation, that you should not go for breast conservation. Okay, so let me explain. This is given in Srivastava. For patient with invasive breast cancer treated with breast conservative surgery, adjuvant radiation of the breast has been consecutively demonstrated to reduce the probability of breast recurrence and improve outcome. Okay, so if patient is going for breast conservative surgery, you have to give adjuvant radiation. There are much more trials is there which start from NSABP06. Just remember this trial. This trial was the first trial to support the adjuvant radiation in breast conservative surgery. From that trial, it shows that if you are giving the adjuvant radiation, chances of local recurrence will be very low. On the and one more meta-analysis is there, early breast cancer treatment collaborative group meta-analysis, which have shown that adjuvant radiation will cause decreasing in mortality if you are giving adjuvant radiation after the breast conservative surgery. So after the result of this meta-analysis, radiation therapy become the standard of care for breast conservative surgery. So any patients, if you are going for breast conservative surgery with axillary dissection or either sentinel and lymph node biopsy, adjuvant radiation have to be given. So here answer will be the adjuvant radiation. Answer will be the adjuvant radiation. So adjuvant radiation have to be given. Somebody is typing that axillary dissection was in the option. If axillary dissection was in the option, then you have to go for axillary dissection. You have to go for axillary dissection. Definitely you have to go for axillary dissection. If axillary dissection was in the option. If it is not in axillary, not in your option, then adjuvant radiation. Okay. Coming to next question, which of the following is false about the Amsterdam criteria? This also I will mention during the class. I specifically mentioned, somebody asked me, sir, can you elaborate the Amsterdam criteria? I told that the trick is there, 3, 2, 1, 0. At least 3 family member, 2 successive generation, at least 1 patient should be affected when FAPV is excluded. 1 patient should be less than 50 years, not more than 50 years. What will be here? Options will be here. FAP excluded, 2 successive generation involved, 3 relative involved, colorectal cancer above 50 year age. No, it is not above 50 year age, it is less than 50 year of age. Okay, right answer will be the D, colorectal cancer above 50 year old. Okay. So see, this is the Amsterdam criteria which is given in Sebastian. 3 or more relative, at least 3 should be there. At least 3 should be there. 3 or more relative with hereditary non-polyposis colon cancer. 1 affected patient is first relative of the other 2. So 2 successive generations should be there. 2 or more successive generations should be affected. Cancer in 1 or more affected relative which diagnosed before the age of 50 years, not after the age of 50 years. Before the age of 50 years. In our option, it is in exam it was given more than 50 years. It is less than 50 years, and FAP have to be excluded. Okay. Okay. So these all 4 criteria should be there for Amsterdam. So right answer here will be colorectal cancer above 50 years of age. Answer will be the D. Okay. Some students were discussing regarding the 3 relatives. No, definitely 3 relatives should be there. Definitely 3 or more relatives should be there. Okay. Coming to the next question. Next question they asked. This question they have directly taken from the Sebastian. Which of the following is not a high risk factor for malignancy in IPMN? Intrapapillary mucinous neoplasm. It is a cystic neoplasm of the pancreas, which is not a high risk factor. See, they have given the option enhancing mural nodule more than 5 mm, man pancreatic duct diameter more than 1 centimeter, jaundice and pancreatitis. Can somebody tell the answer in chat box? Then I will. Can somebody tell the answer in chat box? Then I will further proceed. Pancreatitis is not D. Okay, all are giving the right answer only. Pancreatitis is. See, I have to explain here. Pancreatitis also a factor, but here they ask high risk factor. Pancreatitis is a minor risk factor, so we have to exclude according to the option what they want to ask here. Okay, let me explain. Answer will be the pancreatitis only. Everybody is right here. Okay, see this explanation. It is given in Sebastian only. This line and this table is there. Worrisome high risk feature for intraductal papillary mucinous neoplasm. High risk feature for malignancy. Suppose any patient is more than 1 centimeter. If he is having enhancing mural nodules more than 5 mm on MRI or either CT, and patient clinically having the jaundice, these three are the high risk worrisome feature for the malignancy in IPMN. Okay, high risk feature, high risk worrisome feature. However, low risk worrisome feature is man duct diameter is less than 1 centimeter, enhancing mural nodule, but it should be less than 5 mm, not more than 5 mm. thickened enhancing cystic wall, pancreatitis. See, pancreatitis here, it is pancreatitis here. It is a worrisome feature, but not high risk feature. Increase CA99-9 and cyst growth more than 5 mm over 2 years. So here, what will be our right answer? Right answer will be the pancreatitis, because all three is high risk factor for IPMN. So right answer will be pancreatitis. Okay. Okay. Coming to next question, just this question, I think much more people want to ask. Somebody has some people, some students have given answers to stereotactic radiation surgery. Some have given the surgery. Some have given whole breast radiation. Let me explain. A 55-year-old lady, I think they have given CT also for this patient. Old lady with non-case of carcinoma of breast with good performance status. See, they mention here. They have given the hint. Good performance status presented with solitary 2.5 centimeter frontal lobe brain metastasis. Which of the following is the single best treatment? Can somebody give the answer? Surgery, stereotactic radiation surgery, whole breast irradiation, and hormonal therapy. Answer, somebody is giving the answer B. Just give the answer, then we'll go. Somebody give the answer hormonal therapy. No, hormonal therapy is not the answer. Stereotactic radiation surgery, no. B is not a answer. B is not a answer. B is not a right answer. The exact same to same line is taken from the Srivastava for this question also. No, SRS is not a answer. I am again telling SRS is not a answer. Let me explain. Right answer will be surgery here. Okay, right answer will be the surgery here. Let me explain. Lung, just see, this is in this chapter they have given on this page, specifically they mention lung cancer is the most common source of brain metastasis in men. Breast is the most common source of metastasis in women for brain. Okay. Now see the next line, what they have mentioned. Metastatic lesions tend to cause significant brain edema that initially will respond well to the steroid. I think this question also they asked. Initially well to the steroid, typically dexamethasone. Dexamethasone is used and will reduce the vasogenic edema. Dexamethasone will reduce the vasogenic edema. I think this question they ask, this question also they will ask. We'll cover in next upcoming slide. Okay. Then what will be the next? If the disease is widespread, with short life expectancy and the patient has poor performance status, consideration should be given to possibly biopsy or radiotherapy or palliation. If performance status is not good, then you have to go for these all options. If, on the other hand, a solitary metastasis is encountered, total surgical excision should be attempted, followed by whole breast irradiation therapy. SRS generally will be recommended if surgery is not feasible. If you are not able to do surgery, then you are going for stereotactic radiation surgery. But if patient performance status is good, solitary brain metastasis is there, total surgical excision is the treatment of choice. Okay. Total excision of the brain metastasis, treatment of choice for if performance status is good. Okay, so right answer here will be the surgery. Okay, right answer here will be the surgery. Okay. Whatever options students have given to us, then only according to that we are giving the answer. If surgery was not there in option, then SRS will be definitely will be the answer. Okay, but if surgery is there, then answer will definitely be surgery. Okay. Coming to next question. Gardasil vaccine contain which of the HPV strain? HPV 6, 11, 31, 33. HPV 6, 11, 16, 18. HPV 6, 18, 31, 33. HPV 6, 11, 42, 45. Can somebody tell the answer? I already mentioned a previous question. No surgery was there and SRS is there, then SRS will be the answer. If surgery is option there, then surgery is the best answer over the SRS. Okay. Next option. Yes. Can somebody give the answer? No, it is not C. B. Everybody is right here. B. 6, 11, 16, 18. Let me explain. No, not 30, not 31, 33. Let me explain. This is given in data. Just see here. Cervarix, it is a bivalent vaccine. It is effective against 16 and 18. Okay, it is contain viral-like proteins, particles 16 and 18. Gardasil, quadrivalent vaccine, which is effective against 6, 11, 16 and 18. Gardasil is for 6, 11, 16 and 18. Okay, last is Gardasil 9. They can ask in upcoming exams. The Gardasil 9, which is effective against 31, 33, 35, 45, 52 and 58. Then Gardasil 9 will be effective against all strains 6, 11, 16, 18 with 31, 33, 35, 45, 52 and 58. Okay, here they ask for Gardasil. So answer will be 6, 11, 16, 18. Okay, but remember Gardasil 9 also. Okay, so answer will be the 6, 11, 16, 18. Okay. Okay. Coming to next question. Next question was below mentioned. I think they have given the histopathological slide and they asked what will be the right answer. Okay. Medullary carcinoma of thyroid, thyroid lymphoma, papillary carcinoma of thyroid, follicular carcinoma of thyroid. Can somebody tell the right answer? Can somebody tell? Please mention in chat box. I can see the chat box. Actually, I am having the assessment here for chat box. Can somebody tell what will be the papillary thyroid carcinoma? Yes. So I previously in previous our explanation I already mentioned swarmoma bodies. This is the swarmoma bodies only. Swarmoma bodies, calcification, concentric calcifications bodies is characteristic of papillary thyroid carcinoma. So here right answer will be the papillary thyroid carcinoma. Okay, right answer is papillary thyroid carcinoma. Okay, this is tricky question only. Next question: which of the following radioactive iodine is not used in the treatment of different thyroid carcinoma? I think same question was there. Some other radioactive they have given. I am not aware of that. Only two options I got: 131 and 123. Both or none of the above. Can somebody tell the answer in chat box? Which of the following radioactive iodine is not used in the treatment of differentiated thyroid carcinoma? Please respond, then we will go for explanation. Iodine 123. Okay. Wrong question. Okay. Whatever I got from student, that on the basis of that only we are able to frame the question. But definitely 123 was there in option, I think. Okay. So right answer here will be the 123 because iodine 131 is used for radioactive iodine ablation. Just remember this, that for thyroid scintigraphy or thyroid scintigraphy, three radioactive substances are using: technetium 99 pitakinate or either radio level iodine 123 or 131 for thyroid scintigraphy. For thyroid scintigraphy, not for thyroid malignancy. Thyroid malignancy only and only you have to go for iodine 131 ablation. Okay. So if according to that, if same question was there, then according to that answer will be the iodine 123 because it is using for iodine scintigraphy, not for the thyroid malignancy, treatment of thyroid malignancy. Okay. Coming to next question, they ask for gustatory swelling. Gustatory sweating defined as sweating in response to smell and taste, sweating in response to deglutition, sweating in response to mastication, sweating in response to coughing. Can somebody give the answer? Can somebody give the answer? We'll have discussion on our WhatsApp group also, but just according to whatever options we got, we have framed the questions. So can somebody give the answer? Yes. Answer is right. It is Fresh syndrome. Answer will be A. Sweating in response to smell and taste. Right answer will be the A. Sweating in response to the smell and taste. Nothing more, nothing much I got in Sevistan, because I was thinking that in Sevistan something is given for French syndrome, but only this line they have given. Since most reconstructive methods create a barrier between the remaining parotid tissue and the skin, they reduce the risk of French syndrome. Gustatory sweating. Let me explain what is happening whenever you are going for parotid surgery. If you are not able to put a barrier between the skin and then the remaining bed, there will be the connection between the supplying nerve, which is supplying the salivation and which is supplying the perspiration. So whenever patient is having the smell or salty taste or like lemony taste of any food substance, he will perspirate over that supplying area by the nerve. Okay, you can do starch blue test also for that. So this type of syndrome in which patient is having the sweating over the supplying area, specifically over the near below the auricle, okay, around the parotid area, and whenever he is going to smell or take the food, he will get the sweating at that area. It is called Fresh syndrome. For preventing the Fresh syndrome, we have to put some barrier or either raise the thick flap or some temporofacial fascia based flap we have to make. So the right answer here will be the response to smell and taste. Okay, so gustatory sweating means response to in response to smell and taste. Okay, coming to fourth question, 24th question, they ask a known case of carcinoma breast presented with headache, underwent CT head, and started on intravenous treatment immediately. What is the best explanation for the above condition? First, mannitol for ionic edema, steroid for vasogenic edema, both steroid and mannitol for vasogenic and ionic edema, none of the above. Can somebody tell the answer? Can somebody tell the answer? Somebody tell the answer. Okay, let me explain. Steroid for vasogenic edema. Okay, so answer will be here for steroid for vasogenic edema. I already explained here that it is given inside a Sebastian. Metastatic lesion tend to cause significant brain edema that initially will respond well to the steroid. Typically dexamethasone steroid, which is used to reduce the vasogenic edema. It is that same line is given in the Sebastian. I am not able to find out mannitol as a treatment to reduce the edema in brain metastasis. Even in Sebastian, even in Devita, I am not able to find out the answer. So according to this, the best answer will be the answer B, steroid for the vasogenic edema. Answer will be the B, steroid for the vasogenic edema. So coming to the last option, I think this is the last question which we are going to discuss today. Which of the following antibody is not routinely used for the autoimmune thyroid disorder? I think they have given TPO-AB, thyroglobulin antibody, thyroid receptor antibody, or ANA. Can somebody give the answer in answer box? Can somebody give the answer in answer box? Okay, I will give the answer here. So right answer here will be the anti-nuclear antibody. Okay. This also given in Sebastian that three most commonly measures autoantibody today are anti-TPO, anti-thyroglobulin, or anti-TSH receptor antibody. And measurement of TPO antibody is most accurate and commonly used screening test for autoimmune thyroiditis. So most the answer will be here the D, ANA. Okay. So with that, I think today's session is going to be finished, and I wish all of you will definitely get better rank. Best wishes from my side, and definitely we will hear some good news when result will come. And most of the students from our coaching or from our RRM institute will have good ranks. Best wishes from my side. And second thing, GI Onco part, RRM sir will cover in. So GIT and GI Onco, our Raja Mahendra sir will cover in next lecture. Thank you. Thank you. we can stop the session now.
Okay, sir. I'm concluding the session. Thank you very much, sir. Good night.